5:31. Everyone, Shelley, are you prepared to do the land acknowledgement?
I am. Chase to the Tlingit Haida and Finchdin people. We respectfully acknowledge them as the original inhabitants of Southeast Alaska. Bartlett Regional Hospital is located on the homelands of the Papuan. We are grateful to provide services in your ancestral homeland.
Thank you. Anita? Roll call, please.
Chris Sutherland.
Here.
Dr. Tingy is absent. Max Mertz is absent. Lisa Peterson.
I am here.
Al Geiger.
Present.
Solomon Gross is absent. Shelley Deering.
Here.
Dr. Astor.
Here.
Dick Johnston.
Here. Okay, I would entertain a motion to approve the agenda.
For the agenda.
Okay. We have any public participation? Is there anyone online? Anyone online? Seeing and hearing no one? Is there someone?
That's, it was great.
Oh, okay. Now I would entertain motion to approve the consent agenda.
Vote to approve consent agenda.
Thank you. No objections? And moving right along. Ms. McDowell.
Thank you, Madam Chair. So the hospital capacity update, CCU at 115 patient days in month of June. MedSurg had 500 patient days, OB 49, newborn nursery 38, MHU 148. The ED saw 1,054 patients last month. We do have a COVID patient in-house. Had 5 staff out recently with COVID, 8 in the last 30 days. So it is going around again. I will let Deb give the update. Do you know your holds? We have 2 subacute rehab that are going to wildfire court into long-term care that we're still waiting placements for. I do want to highlight and give kudos to the OR team, the providers, and everybody that helped. We recently opened up our 3rd OR, meaning that Monday was the first day that we opened up the OR, and they were all 3 running simultaneously, the 3rd OR. It was a little bit of a glitch in the system yesterday with Alaska Airlines. We had some providers stuck in Seattle, but the team arranged stuff. Dr. Mather was one of those folks that was stuck as well. But the team came together, we arranged stuff. And then today, again, it'll be opened all this week. Went smoothly. MedSurg was really helpful with getting the admissions, surgical services, all of them same day. The providers and surgeons, of course, anesthesiology. And today we were able to do 4 total joints, 2 robotic cases, 1 laparoscopy, a hand surgery, and 9 endos. So yeah, kudos to everybody that helped that come together. It's and they got out at, I think they were out after 5 today. And I'm happy to answer any questions.
Thank you. Good evening, everyone. So report for Wildflower Court. Our average daily census in June was just a hair under 55 with an occupancy rate of around 86. Get over that. Our census today is 53. We are expecting a couple of admissions this week and maybe beginning of next week. And considering some more. So any questions?
Seeing none? Not forgotten. Heather, please do.
It's fine.
It's mixed up.
It's okay. So thank you.
So the program had 13 admissions for home health with 1 recertification for the month of June. And there are 5 admissions pending and 20 patients currently on service for home health. For hospice, the program had 7 admissions for the month of June and 7 patients were currently receiving service at the time I wrote the report. Hospice average daily census for the month of June was 7. And the hospice average length of stay for June was 35.2 days, which was up by 9 days from before, so that's good. And then there's just a few program updates. That's it. Any questions?
Did we have a foundation update?
Yes, I'm here, sorry. Yes, quick foundation update. The application period for the Edelman Scholarship has ended, and we met with our scholarship committee. We awarded 15 scholarships this 2025-2026 school year, and the total for that was $31,000. The scholarship recipients ranged from everything from nursing to pre-occupational therapy. Let's see, we've got bachelor's of nursing, master's of education, leadership, master of science, family nurse practitioner, clinical mental health counseling, and doctor of pharmacy students were some of the top. It looks like we had 7 returning Edelman and I believe 8 of the newly awarded Edelman scholarships. Only 1 high school student this year. We didn't have as many applications in from high school students as we thought we would, but we're hoping that we get more next year. So, but total $31,000 will be going out to students for the 2025-2026 year. We're offering 2 free wellness activities for Bartlett employees. The first one is on August 1st. It will be held at the Huddle, and it is a paint and sip night. We're going to be having mocktails and painting some northern lights and just enjoying some time together as employees. If someone wants to bring a non-employee friend, they can make a donation to help cover the supply cost, but it should be a really fun night. And during this busy season, we wanted to offer something kind of fun for our employees. In addition to that, we have another free wellness event for Sunday, August 3rd for families. So people can bring their kids and their families on August 3rd at the Rainforest Play Place at the Mendenhall Mall from noon until 2. So both events are sponsored by the Bartlett Regional Hospital Foundation, and we're hoping that people will continue signing up as there are limited spaces for those 2 events. Planning has begun for our donor appreciation event for the fall. It'll probably be the end of September is what we're looking at for that event. And then I've listed the information for the foundation investment for the hospital, totaling $54,127 for the rest of this quarter. Okay. Anyone have any questions?
Thank you.
Thank you.
Yeah.
Thank you. So we'll skip the summary. The summary is pretty self-explanatory. It's in there every month. Tends to be a question. So if you have any questions on that, please let me know. And we'll go on to the CEO evaluation. So the Board Governance Committee met again was it last week? I can't remember, time flies. And so we pinned down a few of the items. I do apologize. There was a couple of edits, just grammatical edits that didn't make this final draft, just due to some timing issues of getting the board packet published. But at this point, we are looking to have a motion to approve moving forward with the CEO evaluation.
Chair, there is one thing that I would like to point out. We left blank in section 2 the weights, thinking that the full board might want to offer an opinion as to how to weight these in order to provide a score for this section. So every board member will be asked to, well, that's what I was just going to say is not important at this time, but we need to figure out how much weight we're putting on each one of these goals. So in the absence of anybody offering anything, I guess, would give equal weight. But some people may think some of these go, one or more of these go.
So we had a couple of, we had a fairly substantive discussion about the concept of weighting and what that should look like and what the span is, whether it's 1 to 5, 1 to 10, 1 to 100. So that's a discussion that we need to have. I want to ask the group something I've been thinking about, to entertain approving the tool and saving the discussion because the board who wasn't in attendance wasn't a part of the this conversation. The board members who were not in attendance weren't a part of the conversation. And I'm suggesting that we approve the tool without the specifics of the weighting.
I'm sure if I mean, there's two numbers that are going involved here. So I want to be sure people aren't confused about the numbers. So in the case of, just to be concrete, the sixth item here would be reduced contract labor. So there, each board member would give a score, might say, oh, well, 100%. Or maybe you don't think it was very good, so you give a lower score. But the weighting is how we weight each of these goals. And I thought we wanted the full board to speak up now about the weight and that the scores is something to be done later. Am I thinking of this differently than you are?
Not necessarily. I guess the question is, are we ready to have the board members who are here and weren't in attendance ready to have a conversation? It's like a number of folks. Yeah. Anybody else?
Excuse me.
This is 3 board members.
I guess if we're prepared to have that conversation without 3 of the board members, we can start we can have the conversation this evening. But 2 of the 3 board members were not, actually, all 3 of the board members were not in attendance for the governance committee meeting. So
We could ask, at what time would we put these weights on if we don't do it now with the people?
that's a good question. If we have any suggestions, there are a couple of ways that we can move forward with this. We can put together a suggestion and have the board members weigh in, or wait till the August meeting, which would go ahead.
No, I'm just, I'm comfortable with approving the tool and then tabling the weights. I don't think that's critical. I mean, I was at that meeting and I think some of us were, but the people that weren't, I think they're.
So Madam Chair,
Yes.
if we're going to table it, I suggest we at least get a start on it. We put some numbers in there and then we can review it. Because if we don't, we'll be in the same position when we finally sit down to do something again later. And I'll just start. I think maintaining an operating margin of greater than 2.5% is more important than some of these other things that are on the list. And I think should have greater weight. And then whether increasing employee satisfaction is more important than expanding orthopedic services or not, I don't really care. But I do think that improving or maintaining the operating margin and maybe improving physician satisfaction should receive higher weights. You want me to talk?
Yeah, I do. Okay, you made the suggestion
So my suggestion to Deb was just that we put out a Google poll together and then all the board members can wait and then we can come back and then take everyone's input and then discuss the specifics and do tweaking versus just in that, time when you get everyone's input into it. I think it'll leave this discussion.
Is that acceptable to the board members who are here?
Madam Chair. And I think there was discussion at that meeting of whether we needed weights at home. And I don't know where that ended up.
That was not finalized either.
Right. So it seems like it's still in limbo.
It could be part of our poll, weights or no weights, and if weights.
But Madam Chair, I would say no weights is the same as giving legal weights. That is
But
a
all
decision.
equal weights.
Yeah.
Cool. I'll say this and then shut up. So this is coming out of the governance committee as a motion. So it's on the floor.
So we don't need a motion in a second. Is there any objection from the members here to passing this as the tool for CEO evaluation?
Good.
I would ask that that Mr. Brown, Mr. Geiger, and the members of the committee, or someone put together, work on the poll, so that we can get that out.
I'd be happy to take care of that for you.
Thanks.
Okay. Lab, A3 presentation.
Madam Chair, I'm gonna have John Fortin.
Hi, my name is John Fortin. I'm the current laboratory manager, and I am here to kind of give you guys a little bit of a background and knowledge of kind of what the laboratory's been working on as part of our A3 project. So a lot of history kind of goes back with this project. It actually goes back probably 5 or 6 years, and what it has to do with is the lab's ability to get reimbursement for lab testing that is not done specifically at our hospital. And so many of the insurance companies had exemptions for hospitals that kind of went on for a long time. But back in November 2023, the hatchet came down. And so they basically said no more if you have what they call a 90 modifier on a CPT code and you try to get that to an insurance company, they will not pay for it. So we saw that as a problem. And so, what we started looking at is really looking at our number of tests that we actually would send out to reference lab. And so I kind of looked at doing this in probably like multiple different steps. So we actually had 4 different steps that we did to get this project initiated. So what we did is I basically looked at the number 1, number 2 tests that we were sending out. This was back in November of 2024. And I kind of got, the lab and everyone else kind of behind me, and it was like, we need to start validating these tests. And validating a test is not just a matter of buying it, putting it on an analyzer. There's actually 5 steps to validation. And so, but basically, we decided to start with the vitamin D and GC, chlamydia and gonorrhea. That's our 2 top tests. We did that for a couple of reasons. First of all, those were the tests that we were giving, kind of throwing on the reference lab a bone. It's because we were making good money on the previous contracts that we had with our reference labs. Like for instance, vitamin D was the number 1 test that we went ahead and we decided to validate that. And so what I was doing back in pre-November, I was paying about $7 a test for vitamin D testing. So now that we can't charge for that because of the 90 modifier, we decided to bring it in-house. But the cost of that test now cost me about $50 a test now to actually do the test. But we were able to bill out, the full amount of $233. So we are bringing money in versus just absolutely losing money. It's kind of a little bit of the background. So as I said, I started, basically with 2 tests, vitamin D and the chlamydia and the gonorrhea. And then, we discussed that back in January. We got those up and going. And then I just started collecting the amount of tests we did per month, and then also how much theoretical money we were, billing out. And so, and it was pretty obvious that those were 2 very high use tests, and that they were actually starting to give us a pretty good return right away, even after our initial cost of validating. And so that was in last year, January of last year. Then it kind of took a little while. We had to kind of wait for some capital projects and stuff. And so then again in July of last year, we had another battery of tests that we looked again at the higher volumes of tests or ones that might have been needed. And again, we did the same thing. We just validated those tests and then basically monitored them out so we could fill out. And then we did it another time in November, and then we finally finished up all of our validating of all the tests that we talked about in February of this year. Before this project, as I said, we didn't have those first 2 tests I mentioned. We didn't have this test called a MVP. It's a multiple vaginal panel. It kind of replaces a wet mount. We also brought in ferritin, folate, vitamin B12. And then we went ahead, got more capital approval, and then we brought in our BioFire and we validated a blood culture ID panel, which actually has been very nice because we can actually give basically an answer to antibiotics, et cetera, within a very short period of time. And then the final testing that we finally started on this year was in February, where we finished up prostate, or PSA, prostate specific antigen, 3 prostate specific antigen, and then we also did ferritin. And so I think, if you look at kind of down there on the bottom where it says, since creating all these different pathways, and this, we just updated this just this month, we billed out about $650,000 worth of revenue, which we would have completely lost before. Now, again, there is cost associated with that. All these validations probably cost me about $150,000 total. And then again, we're talking about bill out money, and with anybody that knows anything about reimbursements and stuff, I don't think we get about 60 cents on the dollar or something like that. So it's pretty hyped up. It's $650,000, but that's what we billed out. I'm guessing right now, since we started this project, we brought in or was able to recapture about $250,000 of actual legitimate cash. Anyway, so yeah, that's been our goal. And right now we're just in the process where we're just monitoring the volumes of the tests that are going out. And then we're also looking for opportunities for new tests that might come up that we can do in-house. The thing is that I don't want to do is I don't want to create, someone will say, well, why don't you bring in this big test? Well, sometimes that's a good idea. But if there really isn't a need on the medical side, and you're spending a lot of money just on capital acquisitions of equipment. And I'll go back to the one test that we did. It's called the BioFire Blood Culture ID. Well, the capital just to buy that analyzer was about $65,000. Okay, so it's going to take us a while for us to recoup that money. But again, I think it's going to actually help us in the long run because it's going to help us maintain our status as a critical access hospital too, because we're getting
Can you just give a little more, talk to what a BioFire does, what it does for patient care, what it does for the patients?
So, a BioFire is a molecular piece of equipment. And so basically what it is most molecular, it's pretty much, you buy a box, that's about it. There's really not a lot of high technology in these boxes anymore. And so all the technology is actually reagent kits. So what the BioFire ID does is previous we were using a blood culture ID, and we were using our other analyzer, our Gene Expert. But the problem was that particular test only did one organism. Okay, so the new panel that we got, it actually does a plethora of different organisms and also gives suggestion on antibiotic use is what it does.
So some of these words you're using make me think this is all using nucleic acid. Is that right? Or is some of these things still using antigen?
No. Yeah, this is all nucleic acid. All moleculars is what you're talking about. Most of the antibody antigen testing is kind of going on the wayside. Most of it's going.
So the chlamydia, the gonorrhea, this is all nucleic.
It's all molecular. All that's molecular. But not all this testing is molecular. So the ones that are on here, as you see, the chlamydia, the gonorrhea, that's molecular. We have of course, the MVP panel, that's molecular. What's the other one we have on here? And then really the rest of these are actually, and of course the blood culture. Then the rest of these are actually just putting on our new chemistry analyzer. So, which we just got a new one last year. And the reason we kind of looked at doing this is because we actually got a little bit bigger analyzer, not quite as big as, it was a little bigger than our last one, and it actually could hold more reagents. So we felt comfortable that we could have more reagents. But it really is a lot of work with everybody on the lab team. They're watching their costs. They're trying to get these validations up and going and approved. We have to pair our results with manufacturer proficiency testing. So it's a lot to bring in a lot of tests. I mean, we had not been doing a lot of validating previously because, as I said, this before with our contracts with the reference lab, it was really beneficial for the hospital. We made a lot of money on that, but unfortunately those days are over with, and the only way we can do it is by actually building these tests here in house and actually building them out directly. See, is there? I can go. I think I've kind of chatted all the way through this thing, but I think really that the takeaway is that it is looking at the tests, because everything about laboratory is about cost and about volumes. The more tests you can send out, reference labs, they send out thousands or do hundreds of thousands of tests, so they can do a test for like pennies on the dollar. Versus us, we don't have those higher volumes. So we really have to kind of watch what tests we bring in, because it's not straight across the board. I'm not paying the same amount for the chlamydia, GC chlamydia reagent as I am for blood. I'm spending a lot more money. So it's just looking at the bottom line, just kind of being smart the way that we bring stuff in and talk to the providers and the other needs that we hear.
Madam Chair. John, can you just explain, so the GC chlamydia, that turnaround time was what, 24, 72 hours prior, and why it's important that we have a quicker turnaround time?
So, I mean, the whole thing with the GC chlamydia and even this MVP panel goes kind of back into COVID. The one thing that we had a real large analyzer that actually did this type of testing. But when we started looking at the cost of doing it, it was just way too expensive to actually put it on that big platform. So when we send something out to a reference lab, you're waiting 3-4 days, and so we as a lab discussed, what was going to be the future of our cobas, the big, COVID testing analyzer. And one of the main thoughts, and it was really working with the people that were in that lab and also working with the emergency room, to understand the need of, there's a lot of sexual health stuff that goes on. In Alaska, it's like one of the #1 issues that happens in our state. And so, the idea is things like, the GC chlamydia, now we can do it in house, and I can have the result back at that provider in like less than an hour and a half, 2 hours. Another one is procalcitonin. Procalcitonin it's a very expensive test for us to validate. But the difference is that when a physician needs to make a decision, they can make a decision with our procalcitonin on our analyzer in 30 minutes, where before we had to send it all the way up to Providence, and then we had the additional cost of all the transport and everything else.
And I think that, to the chair, for me, it's so important, because as you're looking at treating patients, before patients were getting kind of like, well, here's some antibiotic, we think it's going to cover whatever we think you have. And so they were getting antibiotics, sometimes not the right one, or maybe they didn't need one. And so this actually helps, especially when you have moms and stuff coming in who are pregnant, people who have GC chlamydia, they have a higher incident of miscarriage. And then you're treating them also when they're pregnant. So this helps identify whether they need treatment or not, and to be able to intervene early.
Yes. If I might just add that, I think some of these tests, I think, are really, from the provider standpoint, are really a game changer having them in-house. I think you kind of mentioned procalcitonin is kind of a prime example. That test is not very clinically helpful when it's a 4-day turnaround, but when it's an hour turnaround, it has great clinical significance. So I think really appreciate you guys looking at these kind of tests and sort of making decisions, especially with provider input, to sort of figure out where it's helpful, because there's a lot of testing out there, and sometimes bringing it in-house, even if it's financially not great, can have really important clinical.
Yeah, well, I mean, for instance, like on the BioFire, you know, we are looking at other tests to bring onto that analyzer. We did just validate the encephalitis panel, which is, again, we'll probably never make the money on that, but when you need that test, you got that test, and then you can actually help that patient out much quicker. So it is kind of good. But yeah, no, we rely on our providers, you know, coming to me and letting me know what they need. Some of my continued wishes are trying to get ionized calcium back on our iStats. And then I think the other big one is to get some kind of GI panel that we're looking at, maybe putting on our gene experts. So, but those are the next two ones we're going to be looking at here, probably starting in the fall.
Okay. And Luke, you're still in inpatient medicine. Is there anything else other than what John mentioned that you can think of? Because
I guess I'd have to think about that a little more. I mean, I think the blood culture piece, that's a really huge thing, especially for really sick patients. Again, encephalitis panel is helpful. It's probably not something we use a ton, but it does have potentially huge clinical significance. And I think it also impacts babies too, which is rare, but can have a really big impact. So I have to think about that a little more. I think, but the procalcitonin, that I think is one that is really nice to have.
That started with me.
Yeah, I know it's been quite a lot of nagging.
We went back and tried to get that thing in hand.
So
we got it.
And if I may, and perhaps platelets, you guys don't keep platelets because they're just not used much, very expensive.
Right. You know, a lot of what they're kind of moving towards, and this is going to be coming up with our vendor currently, is the use of whole blood. And so they're looking at actually not, you know, because what we do is we give like blood and plasma, and then a lot of even at trauma centers will have platelets. Well, now they're really going back to give them a whole unit of blood. You get your platelets, you get your plasma, and everything like that. I know that there's a meeting coming up sometime in August that both my blood banker and I are going to attend to see kind of what's on that. But the other thing is that, you know, platelets, they don't have a very long, they're like, you know, you only get like 2-3 days, and they're very expensive to keep on house. And so, you know, we can usually get platelets here in about, well, it depends on the time of day, whether you can get the airplane, but I've seen them get here in quick 6 hours, but I've seen as long as 24 hours too, you know, and that's just with our current vendor that you're using that. So.
Any other questions or comments? Thanks for all the work you've been doing.
It's my team that does a lot of that, so it's smart.
Thanks so much.
Okay.
You're welcome to stay, but.
Yep, thanks.
Dr. Mather, I think.
Okay, so for the med staff report, generally, I guess the first thing we can go with is just, so we did review an application fee. This is for new applications for med staff members. It's up there specifically anyway. Basically, we kind of adjusted some of the fees with the hope to encourage people who are applying to really be serious about applying, so we have a lower burden of people just casually applying, but then trying to reduce the cost for maintenance of applications to try to basically support the providers that are here. So slight increase to the initial application fee, and the reappointment fee was eliminated as long as people are putting their reappointment application in a timely fashion. So there's a late fee otherwise. And then there's also a list of exemptions. It's this or maybe the next page. Exclusions. There's a number of individuals that are excluded from this. Some of them are employed physicians, and I think the other important one to highlight, or two, I guess, are the medical residents and medical students and PA students, with the hope of trying to encourage people to come and do rotations here with hopefully to encourage them to come and practice here in the long term. So I think that was also a really important thing for us as mid staff. So we voted to improve it in it's now in action.
Yes, as I recall, there was not any great deal of concern about this. Seemed like a reasonable suggestion from the greater medical staff. So I'd support it.
Other questions for Dr. Matthew or?
Madam Chair, I would guess financially, I don't know what this changes in supporting Bartlett for the cost of credentialing. Is it a big difference? Is it a small difference?
Well, we weren't really following the previous policy. So this is kind of an effort to sort of clean up the policy and then hopefully follow it. I can't remember, we did have a list. I can't remember what it actually added up to for the initial.
Material, it's more just
There's some cost. I think really honestly, the main goal for having an initial application fee is trying to prevent people from saying, well, I might go work at Bartlett, so I'll put in for an application, and then having our med staff office have to put in a lot of work. It takes a lot of work and time to get these files credentialed, and the burden is relatively high with all of the folks that we're credentialing now with locums and telemedicine and things like that. So trying to create some barrier for people to not just sort of throw their hat in the ring if they're not really planning on coming and working here. The goal, yeah, I don't know if it breaks even or not, but
we did list it out like it. On certain instances, it covers the fees, and there was an increase. We used to charge $150. We moved it to $200, so that's closer to what the average is. Like this is like we do the different we have to go out and collect information. These are the fees we pay. This doesn't even come close to covering staff time.
This covers also the compliance piece that it wasn't being followed or tracked appropriately, Shelley. Good to hear.
Questions or comments? Sounds like a worthy agenda. And
we got it cleaned up, I think.
well, and to they got some commitment to so do we have a motion?
I'm sure I'll move this forward.
Second.
Are there any objections to this motion? Seeing and hearing none, the motion is approved. Okay.
There was just a couple more things I was gonna add. Sorry. So I guess in our meeting minutes, you guys will also see, but we did have a discussion around honorary status. It will be a change in our bylaws. I think probably not something as we previously discussed that needs to be voted on here, but change the verbiage a little bit to allow for people that are in honorary status, which are retired physicians primarily, to be able to attend committee meetings, which our new bylaws had not permitted. The thought that they have historical knowledge and potentially had things to offer to those various committees. So we voted to allow that. And then there was a change in the health and wellness, their charter and the bylaws. Physicians that are having substance use issues or things like that, that has historically been dealt with through MedExec. And so the verbiage had been changed in the new bylaws and reverted back to what we've historically been doing. So MedExec would be responsible for dealing with disruptive physicians or substance abuse issues as opposed to the Health and Wellness Committee. And that was voted on as well. So yeah, much change. And then those were kind of the main things, I guess, just kind of a general announcement to the med staff, just so people here know. And I guess also a thanks to Joe. So Search previously had the contract for WIC in Southeast Alaska, and they have dropped their contract for WIC. So that left Southeast in a little bit of a bind. I think Joe and his team looked and Kim and looked into trying to see if that's something that Bartlett could fill in for, but not really feasible. You have to cover all of Southeast Alaska, not just Juneau, so that obviously makes it pretty challenging to do for Bartlett. So it's currently being done remotely, which really isn't ideal at all. And so kind of an unfortunate transition. Providers are not really notified, which is a bit frustrating for us caring for mothers for babies. So that was kind of what we discussed from the last meeting.
Sharon? So when you say it's being done remotely, what does that mean?
So the contract was picked up, I can't remember the name of the group, but based in Anchorage. So there is no longer a WIC office, here locally, or I guess theoretically anywhere in Southeast. Which I think is particularly concerning because, you know, this is a relatively vulnerable population, and I think it's kind of unrealistic to think that they will all have access to telemedicine opportunities. So I think, unfortunately, a really big loss for all of Southeast and certainly for Juneau. And I think the OB department and I think Kim are kind of working on trying to figure out how do we help support our local community. But yeah, sort of a not very well. We were notified by email after sending applications that they were no longer doing. It's kind of a frustrating transition for a population that benefits from that support.
It's too bad. Thank you guys for trying to work on some type of solution.
I have a question for either of you. So what is the process if it's remote?
I haven't actually had a patient go through it yet. I don't know if you have a better answer to that, but
Chair, I'm not sure either. I know from the, looking at the grant process, or, you know, what was required. It's pretty intensive as far as, you know, you have to make sure the stores in the area provide certain products, certain, you know, that are covered by WIC. But I'm not sure how they're doing that remotely.
And how do our patients access it remotely?
I think it's telemedicine access essentially. But I haven't had patients go through it.
I'm not sure.
Anything else?
Yes, sir.
Any questions, other questions for Dr. Matt? All right. Let's move on to committee meeting update. The joint conference, the minutes, as I used to say, the discussion. However, there are a few things that I want to draw your attention. We had a really robust conversation at the joint conference. That ones I want to draw your attention to. We've talked about this a little bit. We did talk about the medical executive committee compensation, and I think we're going to move forward with that.
Yeah, yes, kind of add to that, so I should, this last section, we did, we intended to talk about it at our med staff meeting. Unfortunately, we talked about it kind of theoretically. The hope was to present the med staff with the actual contracts and couldn't quite get them from the lawyers in time to make that meeting. So there didn't seem to be any objection med staff in kind of talking about the general structure. My hope for transparency was to present the med staff with the contracts, and then hopefully we'll have a vote next month on that.
Great. Get this moving forward in the med staff. So that was a good conversation. We kind of are moving forward with that. We also had a discussion about the chief medical officer. We've gone back and forth for a while about what the necessity of it and what it would look like. And I guess after all the discussion on both sides, both on the hospital side and on the med staff side, it's and Joe, you can correct me if I'm wrong. We're not in a position to move forward with that right now.
And so the decision not to move forward is kind of financial, waiting to see what happens with the Medicaid cuts. I mean, I know there's positions on both sides of the fence. We felt, you know, there's some that are strongly, you know, in favor of it because it would add some benefits, but there's also some that is. Right now, we're in a hole to see what happens with the whole HR 1 bill.
We did spend some time on the OR block time, which is something that is talked about all the time. I don't think that there's any final resolution on it. I think we'll, but well, if there's been updates since then, so
So in the first phase of this was what Ken talked about in her reports. An anesthesiologist and to open up that third OR. We are in discussions with CRNAs. We're going through the DOPs, the privileging process for the CRNAs. So Kim has a meeting set next week to go through those, or later this week. Then we also have scheduled an anesthesiologist to come back in August to do another week of the 3 ORs, kind of test and processes how it works. And with the goal of bringing in the CRNA hopefully in the month of September, having the third OR open more often or every day, depending on what we can get with that. I think
That's good news.
so that should expand block time and hopefully alleviate some of the restrictions we had. We've already seen it this week. It seems like our staff's getting out on time, getting a lot of procedures done. So it's been our sample size is over 2 days.
Go with it.
Yeah.
That's great news. It's been a while coming. So that's good to hear. And then the final conversation that, it came up in the comments, but it was a significant conversation on the difficulty on neonatal resuscitation protocol, and who was trained for it, who was willing to participate. So I'm not sure where we're at finally with it.
You want me to take it?
I mean, great, I'll add on. Okay, either way.
So we were approaching this with a kind of 2 different phases. We have the clinical appropriateness of the patients we have. So we have a group of physicians that's meeting on how we reduce the risk in the patients. So are we doing the right burps that we're able to do locally? And how we mitigate some of that risk with the staff and the providers. On the backside, we are looking at how do we pay for the NRP call that we're currently getting today. And so there is a different study that we've engaged a company with, so we make sure that we're within fair market value and then what we're doing is appropriate. So it's kind of a bifurcated approach. I think those 2 pieces together should ensure we're able to continue good care.
I think that NRP, I guess for everybody, if you're not familiar with what that is, I mean, it's someone who's on call to provide resuscitation to a newborn after delivery if they have any issues. Many newborns are born and they make that transition just fine, but when that doesn't happen, that becomes a very critical provider, and the obstetrician can't be in 2 places at once. They need to be taking care of the mom, and so having an on-call person for NRP is, I think, really important for OB safety and providing care for mothers in our community. So, trying to address the patient population, and we're doing that through the OB and neonatal committee. It's finance the reimbursement portion, but I guess the important piece to highlight for the board is I think the NRP call coverage, and again, the financial support for that call coverage, I think is really critical to be able to provide safe OB care in our community. So.
I'm kind of curious, how many physicians are there that can provide this?
Well, so it's a somewhat complicated question to answer. Dr. Dressel, obviously, pediatrics takes it, Chamber, and there's a couple other hospitalists that are still NRP certified. Everybody at Valley Medical is NRP certified, but not everybody is necessarily taking that call all the time. So it's primarily Dr. Dressel and the hospitalists. Valley Medical will fill in some, but have been, and sometimes we do cover our own NRP occasionally, but I would say we often do rely on the NRP provider who's on call.
If I was counting right, there's 2 providers outside.
No, there's more than that. So there's Dr. Tainter and Dr. Dressel and Dr. Cook, yeah. McKinney. So there's a couple hospitalists.
Okay, I think we have 4.
We have lost a couple of the hospitalists, and I think that's again kind of the discussion about risk of deliveries. Should we be delivering higher risk mothers in our community? Sort of the challenge of sometimes it's safe from an OB standpoint to deliver a patient, but the risk for a baby with difficulty making that transition is higher, and so kind of trying to figure out a structure to have good communication amongst the two teams. think there's been a little bit of a change with more obstetrician providers in town because they don't, while they're certainly familiar with risks to baby, they're not the ones doing the resuscitation. Historically, medical was wearing both of those hats frequently, and so I think it was a little bit what direction, what resources we have in our town. You know, if you're in Fairbanks, you know, you have a higher level nursery there, so you can deliver women that are higher risk. You can take care of these babies and to have more limitations on the nursery side.
The other thing we have to keep in, I'm sorry.
Lisa,
The other thing we have to keep in mind is a laboring patient can come in just perfect and then you need that.
So,
I mean, so
yeah,
it's not an exact science.
no, I mean, I think it's a critical need, even if you are screening, right? I mean, there's women that can't leave town, even if they're high risk. I think part of what we're kind of trying to do is in situations where we have the ability and the luxury of time, which isn't always the case at OB, can we do a better job screening so that we have higher risk mothers deliver out of town if they're early gestational age, things like that, kind of do a better job of picking who we elect to deliver here, and then obviously we deal with whatever comes in regardless.
Right.
And I just want to make a comment that NRP is a national certification that nurses, physicians, and respiratory therapists get certified in to provide that specialty care.
Right. Yeah. It is a team, certainly the team approach. Trying to make sure,
But you need a leader.
trying to make sure that we have enough providers that are willing to stay in that pool. It absolutely does involve everyone. And the hospital does a great recertification program here locally, which is really nice to allow all the team members to train together. So.
Elsewhere. Are there, that was pretty much the gist of our conversation. Are there any other questions or comments about conversations at the joint meeting? Let's move on to the audited finance, and I think you're going to take care of that.
Yeah, I will. So, the minutes accurately reflect the meeting, and just a couple of the high points. May, we had a positive bottom line, and that was due to increased patients in med-surg CCU, and also an increase in OR and imaging, which we can contribute partially to our having our orthopedic services. So that's a big plus. And then we did look at 2 4-year budget forecasting for home care. And we knew going into this that this was not going to be a revenue maker for us, but it was an important part of our community. So we will just continue to monitor that and to look for ways to find additional funding. If you have any questions, ask those too.
Are there any questions or comments about the finance committee? Governance.
Well, of course, the minutes actually. Well, there are a couple of things I want to refer you to in a minute. So we did have a discussion about the board of education. That's something that we have to do every year. We didn't make any decisions. Joe's going to look into some topics. But for those of you who aren't at the meeting, if you have any views about what you think we should be educating ourselves on, we should just tell Joe about that. Go up to the next meeting. The CEO evaluation, we've discussed that already. We don't need to do anything else. And then finally, the long-awaited board policy manual is in your package. I should offer a prize for everyone who found a little typo or clarity. I'll give some kind of prize if you can find one. But this has come out of the committee as a motion, so as an action item, it's a motion. Either move to amend it.
Okay, is there any discussion? But this is our second reading. We saw it in last month's meeting. This is the time to vote on, last chance to comment on the policy manuals.
Madam Chair, I just want to say thank you to Hal and the committee for all the hard work that went into that. So thank you.
Excellent.
Glad I didn't have to. put that in there.
Are there any other comments? Is there any objection to the motion? Okay, seeing none, the motion is passed. The policy manual is ready for implementation. All right.
Thank you. The moment we've all been waiting for. So the big thing we've been trying to digest over the last couple of weeks is the impacts of that one big beautiful. We did have a staff member from Senator Bukowski's office reach out and invite us to meet with her on Saturday, so we took the opportunity. So me, Ken, Angela, and Gail, and plus Deb was here. So she went over kind of all the stuff Bukowski did, how they see the bill impacting us. Some of the big takeaways is Alaska kind of is insulated compared to other states. There's some exemptions that are specific to us, the rural areas. And it's going to work around the work requirements that would push that out to calendar year 2029 before we start seeing the big impacts. So from a Medicaid standpoint, we do have a few years to kind of prepare and get ready for some of the changes that are coming. The state has to do a lot of work on their side of the community engagement. Tracking is going to work. There is also a lot of work the state has to do on the application process. So there are some error rates that the state could be fined for at some point. So any error rate above 10% would induce a 15% penalty. Right now, Alaska is at a 24% error rate. Prior to that, we were at a 60% error rate. So we have done work. We've come a long way, but we still have a lot of work to do. The senator's office felt like that was the biggest area of concern from their perspective. So the state has some stuff to do in the next 2 years to get ready for that. There were a lot of exemptions specific to Native Americans, rural areas with certain limit rates. So a lot of the boroughs are already protected. It's insulated from many of these work requirements. The big thing I see as being an issue for us is there are some of the ACA subsidies that will be impacted here shortly. So starting January 1st, we can see a decrease in commercial insurance. As we looked at, I talked to Tammy about this, and we didn't know a way. When someone comes with Blue Cross, you don't really know how to get Blue Cross or Premier. They just have. And so we don't know if that was through ACA. I mean, some of the employer plans we know, but not some of the other plans. And so we're going to have to monitor that when January comes if we see any decrease in commercial insurance. We also had a lengthy discussion around our rural demonstration program or project that we're in. So as I've talked about this in the past, it ended on 6/30. The senator's office has been actively engaged with some of the other states that are impacted. They feel the senator from Wyoming is going to take the lead on that because they have the biggest impact. As everyone knows, that it's worth roughly $4.2 million to the hospital annually. But there is every confidence that that will be removed within the next, either what happens in September or by the end of the year with the retro back to the second. This isn't the first time the hospital has been in this bucket. This will be our third go to this very process. So the way we're timed in the kind of the way the study is, we're always one of the first ones that drop out. So we'll keep playing this game until we make it permanent or we find a different outcome. There was also significant discussion about the SOLS Act. There were some provisions built into the rule where CMS will be making some change to OPPS, the outpatient respective payment model for Medicare. Where we see some increases starting in 2027. It's roughly 500,000, but 550,000. So it is a material change, but the SOLS Act would be a long-term fix to our outpatient reimbursement problem. So we continue to push on that. They felt like there was still a good chance that could get in because it was one of the things they've worked on with our senators when they went to at the last signature. We don't know if all of it will spent up though. So we'll see how it gets moved forward. So not going to hold our breath. I'm more optimistic about the rural demonstration getting extended than SOLS Act, so we'll continue to watch those. I guess the good fact as we look at this is we are coming in this with a positive operating margin. So we have done the big school this year. Yeah, I think I look at June, you know, that's it's catastrophic and I will have a good opportunity. So that's what I know on HR one as of now. I don't know if there's any questions specific to the bill.
Have you reached out to Sullivan yet?
Yeah, I reached out to, we've had conversations with Sarah Bell. I think I forwarded an email to the, most of the board members after that discussion. She was positive. She was more positive about the souls that we're trying to set the meeting where you could hopefully talk to Kennedy. I don't know what his title.
HHS.
HHS secretary, they're trying to get some. There is a potential where they could do some stuff through CMS, through HHS, to mechanisms, but those are less likely than legislative, so. We continue to take every opportunity to plead our case, talk about all the points, inpatient reimbursement, outpatient reimbursement. I guess the other big piece of this I didn't talk about was the 50 billion rural transformation funds that they were able to secure. So it was in two different buckets, 25 billion each. The first 25 billion is basically a competitive grant process. The state has until December 31st to submit their grant. I know that Jared Tosin from the AHA from the association has reached out to the state trying to help with that, to help the state put in an application that would be competitive and transformative. So we get some of those dollars back to Alaska. The other 25 billion is kind of a fixed amount spread evenly over all 50 states, so we'll get that piece. I think they're still trying to determine how they allocate that. So we're advocating, it should go to all the people who could potentially be affected. Since we do have a couple of years, I know the state has to build some programs. They talked about some systems that they have to build, so those might be in conversation as well. Some of it's with the workforce requirements, tracking stuff, so the state has some issues. We'll continue to push, plead our case, I guess, in the case for all providers. Yes, next on my report, it's our first official day of care at Bartlett County Medicine will be on September 2nd. So we went through and signed the agreement. One of the providers was out of town for a family issue, but he signed on Monday. So you'll start seeing that all moving forward quickly. We have a lot of changes we have to put in place, notifications to patients, contractors. But we went down to with Dr. Malter and Dr. Cathan yesterday and got them to sign. So that process is officially off and running. The second part of that is we have been working with additional providers. I kind of go to that. One of the providers we actually signed a contract with yesterday. And so we have a provider will be joining the practice, kind of waiting for them to work through their process with their employer, assuming everyone can guess who that is. So the news to come hopefully next week. We've talked about additional specialties coming in. I know we're working on a rental agreement kind of with the cardiology group at this point. They're looking at starting small, maybe a couple of days a month. So Kim's been in point of contact with them. We're trying to make sure provisions are in the contract to protect the hospital as well. We're also, the dermatology group that we spoke of is also moving forward. I know they're actively engaged with Chris Miller with the DA, trying to get that set up. So we're getting to a point of there's been a demand on the current space we do have that far exceeds the space we have. And so Virginia Mason didn't care. They will rent the space every day of the month and we'll figure it out. And so they wanted everything we had. We could. We have other, competing space and we're trying to make the best decision for the hospital and the patients and the whole medical community. So.
If I may, are you talking about Dave Miller space?
Dave Miller space.
Okay.
Specifically. I mean, if I had more at our seat offer up, we go that avenue, but that's the only space we have right now. Did be that. And so our goal is, and what we kind of talked about strategically, is we want to create a space that visiting specialists can come practice in, and it's kind of good for all kinds of different specialties. So that's what we're trying to design. The other thing that we had kick off this week or last week is our master facility plan. We have a contractor on site. We met with staff, toured our facilities. We had lots of good discussions. We've sent them a massive amount of information at this point. They are setting up subsequent meetings, so we'll be starting to put together some stakeholder meetings. They want a subset of board members, a subset of physicians, have an advisory committee put together, so some of you will be tabbed for that. There are obvious inclusions to this, but I think we're looking for roughly 15 people, right, Anita, something like that. So I practiced down with Dad, checking out what makes sense, and meet with the SLT and trying to figure out we have the right people in place to have these discussions. There also might be a community engagement piece. We're trying to flesh out what that looks like. Discussion around should the community have impact and how do we get the right voice into the room. So we're still looking at that, I guess, at this point. Anything else? Is there any questions? Feels like there's a lot going on.
We packed a lot into this last month.
It's been busy. Oh, yeah, on the next bullet. It's a different bullet on the agenda. I think sure it's my report.
Any questions about the CEO report? Okay, next is the
Dell workstations refresh. So during our capital budget project, there was a line item that was the Dell workstation refresh. And so the board asked us to bring that back for discussion. And so after we actually reviewed this is an operational expense. It's not a capital expense. And so what we've looked at is we've looked at two different ways to move forward. As you can see, we haven't replaced computers really since 2019. So we've had some old machines. Or Dell's over there on our, I think, second laptop in a week. Marginal at night.
This is the 2018 version instead of my 2017 version.
We have some opportunity for improvements around that. So what we've looked at is what we've gone through, we've created a 3-year plan, how we're going to go through and systematically replace all our workstations. Looked at both a lease option through Dell and just a purchase option. Angela went through and did kind of the analysis of ROI, the 5-year projection on what the cash flow so it looked like. With net present value, the cash flows. Lease is marginally better on a cash basis. I believe it was 20,000 over 5 years better than the actual purchase. But it does come with some drawbacks, and they're noted in the A3 or the DPT that's attached to it. Some of them are we have to have, it's a 1-for-1 replacement, right? And then when you give your lease back, there's no cash value to those computers, which there's a potential turning value of the purchase. And then as we add machines and grow or expand, leases become cumbersome to manage. So if we buy a block of 250, whatever computers is, and we'll have that lease, that's a 5-year lease, and then we add next year's and the years after. Let's say we buy computers from there, different ones. So you're managing all these different leases. So after further analysis, and we've kind of talked this through, I feel like the best way forward for the hospital is probably to purchase this first series of purchases so we get them implemented and not do the lease just because of various reasons, the turning value, having to manage each device separately, having to manage all the leases separately, and just the associated. And so we brought that for discussion. I'm open to suggestions. This will be a rather large operating expense as we go through the year. We're trying to work with the press on how we roll this out. So obviously we can't buy them and implement them all today. It has to be done. And there's more background. So we ran this through our executive steering committee, which is something Ian helped put in place. So we went through some of the documents that are original to that. So IT has more of a burden as they go through what they're going to buy. And so we tried to give you the full picture of how we looked at this, if that makes sense. So
I understand how the whole lease thing works, but after we buy them, what do we do with them after that with those?
There's actually a turn-in value, so we can potentially turn it back into Dell for whatever fair market value of that machine is at that point. If you lease it, it just gets turned back in. There is an option where we could potentially have some.
Yeah, I've got 2 questions. So it sounds like you're locked into Dell. We replaced these with Dell machines, but Dell's just.
Words of judgment, why you ask that question? And so as we look at our system and kind of our whole platform, I mean, a lot of our back-end servers are based on Dell. And so Dell's kind of one of the big providers of that. It is a GPO contract, so we don't really have that. So there's multiple reasons why Dell.
The other question I have, and why is this an operational expense instead of a capital expense?
So with cost-based reimbursement, which goes back to our cost report, you want to capture the cost in the year it happens. So my goal and Angela's goal is to get every expense into every year you can. And so capital threshold for Medicare is $5,000. None of these individual computers are over $5,000. So we switched our capitalization policy to each. So if each one is a piece of capital, I mean, they all, you know what I'm saying?
Yes,
It has to be over 5,000 per computer. So that's why it becomes operational. Doesn't matter if you buy one or 500. It's not over 5,000, doesn't matter.
Good. Two questions for you, Joe. So is this a decision that is, you will be doing this for the next 3 years?
Yeah, we're basically starting the sequence of, once we do your first, we have all the departments kind of planned out over the next 3 years. There's obvious, someone's breaks we have to do a sooner replacement. So there might be some ins and outs, but we're basically starting a 3-year refresh. And then, as you've seen in the document, mostly IT does these computers as we get them are actually have a lifespan of roughly 5 years. Dell, hers is worth 7 years. So we'll do this 3 years, get refreshed, and then we'll start planning the next refresh, year 6 months, go back through this process again.
Any other questions, comments? Not an action, it's an informational item, but something we probably need to know and should be interested.
And you see minor equipment jump up 51 month.
Mr. Tiger was not able to make it this evening, so hopefully we'll hear from him next month. Again, we're on my report. Much of Joe's report involved I was participated in, and he probably did a much better job than I would have summarizing the discussions that we've had over the month. As you've heard, it was one heck of a busy month, and it's going to continue for a little while. Well, actually, who knows how long it'll continue, particularly with the big beautiful, the fallout and the understanding of what's happening. And then also we're coming up on another federal budget cycle. We're 3/4 of the way into the year, the federal year. So we're going to be starting to talk about this again soon. So a lot of change and a lot of uncertainty for us and our community and the services that we'll be able to provide going forward. Hopefully, thankfully, we do have, based on our location, we do have some advantages over a lot of the lower 48 states in what the reimbursement looks like. It isn't as good as it used to be for us. It won't be as good as it certainly won't hit the level that some other hospitals, particularly rural areas, will be facing going forward. So more to come on that. Any questions for me? Okay. Board calendar. Yeah, 4 scheduled meetings on the calendar. Planning committee.
We had discussed, actually, the chairs of the finance committee and the planning committee, we're trying to get them together, but both of them are absent tonight.
Yeah.
So our hope was to merge those into a joint meeting so we could discuss about the housing issue that we talked about in prior months. Potentially maybe bump it where it aligns, where the master facility planning team would be the hospital, not their board at that level. So we're trying to coordinate. Meet those things.
So it sounds like let's leave these on the calendar as they are and assume that if we're successful in creating a joint meeting, you will hear how that falls out. So I don't think we need to talk about either of those. The credentials committee meeting is always on the first Tuesday. It's a closed meeting. Are there any other committees that need to meet this month? Or actually in the month of August?
Anyone with the quality committee,
September.
September?
And the governance committee, most of its work is
Well, we have one more little item, but I was thinking we put that up till September.
Yeah.
You guys have an idea of when in September? So I can plan.
Well, I guess we could talk about that.
We haven't decided, I just kind of want to steer away from particularly.
why don't you share with us that particular week?
First and the second,
First and the second weeks?
yes.
Oh, I'll be out of town the week of the 15th. Well, we don't have anything that really must come before the full board. Even if I know this really breaks with precedence, we could have after the 20th. Wait a minute, when is the 23rd, yeah. Yeah, we could have. Or we could put it off for the next, it's not urgent. But you're saying we could not have it the week of September 1st or the week of September?
If you do it the first week, I mean, I guess I should clarify. I will be on the East Coast and I can attend remotely.
But even the week of the,
The week of the 8th is horrible. I got to travel for both family and I also have to travel for work. So that second week is absolutely terrible.
how about the 15th? With the 15th in September?
Except for all of us that we AHA's annual conference is that week. So there's
So,
me going into it, or me giving into our.
it looks like what would be best would be after the meeting, or just put the meeting up. So we have a couple.
We have a couple things that are coming up. I don't know that I would want to put it off till October. We do have to get started on the board evaluation, and we do have the CEO evaluation that's coming right up as well.
So maybe we should talk about having a meeting in August. How about the week of August 18th?
I can do that as long as we don't meet on Friday. But I can do the whole rest of the week.
I want to just toss out there that mid-August is what has happened the last couple of years. And this I have my fingers crossed that nothing will happen to my house again this year. But just know that if the HESCO barriers fail, I may or may not be here.
This might be a good opportunity to come get beat driving.
Maybe. I don't want to take it as long as it took me last year to get back into my house, though.
Pending natural disaster.
Pending natural disaster that happened on the exact same day 2 years in a row, so. Coming right up.
Well, what's the pleasure?
You can skip for me that I'll be here in town, and if I'm able to, I will be in attendance of anything we schedule.
We just say the 18th. No, I will be, I'll be out. I'll be out of town. Yeah, I don't have that on this. I'll be out of town 14th to the 20th. Looking at the wrong calendar. I'll be out of town the 14th to the 24th. So it'd have to be the week of the 11th. Sorry. Week of the 11th. The catastrophe won't have happened to you.
Yeah, we'll be before it. I think it's-
We did the 11th.
You can talk about before the flood.
Well, if it happens on the 6th again, they're projecting that, I heard from the, probably whoever it is that's studying it, that they're projecting that the basin will be full on the 8th. It'll start overtopping on the 8th, and it usually takes 3 or 4 days after that for the ice dam to burst. So
So you'll probably be evacuated, so that'd be a good day.
you think?
But I suggest the August 11th at 3 to 4.
Fine with me. Lisa, well, that work.
Second,
August 11th.
11th. Sally, I am very sorry, but I will not be able to attend that meeting on September 11th. I'll be at Fairbanks for 3 days for a meeting.
You,
Sorry. And then there's no way I can break away out of it.
how about the 25th?
No, this is the.
Yeah, it's
September.
September.
She's okay with you.
Oh,
Now.
You're good.
I mean, you guys can go ahead without me. I'm just, I can't. There's no way I can make it.
We have time to plan for that when we come back. When we.
I'm just letting you know right now, there's no way I can attend.
Okay, yeah, I'll work with Gail
Yeah, that's fine.
and Dr. Hester. Then the following week,
I'm sorry. Don't usually.
Okay, I think we have time to resolve the September issue.
I'm just letting you know ahead of time, so it's not.
Want us to resolve it?
No.
Oh, we have time. I thought you meant now when I was gonna
No.
say.
No, I just wanted to just say, well, yeah, I knew 2 months ago, but I just kept it to myself for fun.
Okay. So, I'm going to entertain a motion to approve the calendar with potential change, as is, with potential changes. We've, one of the changes is the addition of a governance committee on the 11th. Okay.
Motion to approve the calendar with the addition of the governance meeting on the 11th.
Lisa seconds. Any objections to that? Seeing none, the calendar is approved. All right, now is the time for board comments and questions, isn't it? Yeah.
Well, driving over here, I got a call from Bruce Weiler, who sent me an email since we've been here. Several years ago, Dr. Rada and I tried to interest Ira Byron in coming to Juneau to talk about hospice. Dr. Byron wrote a couple of very interesting books, and he was kind of the third wave of hospice promoters in the United States. And he was hired by Providence and worked for Providence for a number of years, setting up their whole palliative and hospice program and trying to promote it. And apparently, he's now agreed to come to Juneau, so he'll be here on December to speak to the medical staff. He's also going to have a public presentation to try to just get the community thinking a little bit more realistically about hospice. On December 10th, there's going to be a meeting for pharmacists, nurses, and hospice volunteers, CNAs. And so I just thought I would mention that. I think Bartlett should definitely try to do everything we can to promote this in the community and to partner with the Foundation for End-of-Life Care. Presentation to June. IRA, BYOC, BYOCK. Or IRA, BYOC.
Any other board comments? Okay. Let's, I would entertain a motion to executives.
Madam Chair, I move the Board of Directors of Bartlett Regional Hospital recess into executive session to discuss several matters, including those which by law, municipal charter, or ordinance are required to be confidential or involve considerations of records that are not subject to public disclosure, specifically the credentialing report, the medical staff meeting minutes, the patient safety dashboard, and legal updates. And Madam Chair, I ask that you be allowed to choose which staff remain.
Senior leadership.
Okay. Fine.
Thank you all. Let's take a quick break before we go into. Did we second it?
Oh, I see.
We didn't.
Yeah, just take a, come back at 7:05.
Madam Chair, I move that we accept the credentialing.
If there's no other questions or comments from the board or anyone else, we are adjourned at 7:29.
7:30.